Hi, this video is going to be tying up our discussion of ventilation, and we're also going to cover how we measure the lung capacities and also make sure that we're on board with differences in the partial pressure of gases throughout the body so we can talk about how internal and external respiration happens. There are going to be a number of SLOs we're going to cover in this video. All of these are going to be labeled on the slides that they're on. There are a couple that are either seem out of order or look like there are a few that are missing. That's just because some of those are from the original division of kind of pre-reading and after lecture content. You know, the ones that are missing are usually places where we're talking about the upper respiratory tract, like the trachea and the bronchi and that kind of thing. Okay, so first, let's remind ourselves of the different pressures that we have to be considering here. Remember that the morphology of the lung is that we have the multi-lobed lungs that are surrounded by their serous membranes, which are called the pleurae. Now, the pleurae are like vacuum sealed on top of the lung. So the pleurae are actually attached to the inside of the thoracic cavity as well. So as the thoracic cavity changes its size or changes its shape or changes its volume, that's going to cause changes in the volume of the lung ultimately. So you notice if you look at the numbers first for the atmospheric pressure, it's 760 millimeters of mercury at sea level, but we're going to call that 0 for the purposes of kind of equilibrating our discussion of how the pressures work with ventilation. Notice that the atmospheric pressure is the same as the intrapulmonary pressure. Now, that's true if your lungs aren't moving. But the thing that's going to happen is as the lungs change their shape, the intrapulmonary pressure is going to catch up with whatever the atmospheric pressure is. Now, the intrapleural pressure, this figure super exaggerates the thicknesses of these different layers, but this is okay as a diagram to say that intrapleural pressure, notice that's a little bit of a negative value there. That negative value indicates that kind of vacuum sealing of the two. And then the transpulmonary pressure is just the difference between the intrapulmonary pressure and the pressure of the pleurae. Pulmonary ventilation is a mechanical process. Pulmonary ventilation is a purely mechanical process, this breathing, that's going to depend on volume changes within the thoracic cavity. These volume changes they'll lead to pressure changes, which is going to cause the gases to move to equalize pressure. And they're going to be following Boyles Law, which is this relationship between pressure and volume of gases. So just to review with how inspiration happens, remember that in mammals, inspiration is an active process. It's an active process because muscles contract to make it happen. So the first step is the inspiratory muscles are going to contract, which is going to make two things happen. First, the diaphragm is going to drop, and so that's going to increase like the height of the the depth of the thoracic cage. And the intercostals, when they contract between the ribs there, that's going to have the effect of kind of hinging the ribs so that the sternum is raised. So by raising the sternum and by dropping the floor of the thorax, that's going to make the thoracic cage increase in volume. So when it increases in volume, that vacuum seal of the pleurae is going to cause a stretching out of the lungs, and so now the volume inside the lungs has become larger, so air is going to get drawn in. Okay, so inspiration, active process, driven first by the contraction of muscles. Expiration, in this case, it starts with muscles again, but in expiration, it's just the elastic recoil of the muscles as they relax that's going to cause the sternum to drop down and the diaphragm to raise up. Those two things together are going to decrease the volume of the thoracic cage. As the thoracic cage volume goes down, then the pressure inside the lungs also increases, so air is going to cause to get released out during that process. Now, this is what we call passive expiration. So if your normal kind of tidal breathing that you're probably doing now, where just kind of the relaxation of those muscles is what allows the air, is what's going to cause the air to escape. If you're actively blowing, though, if you're trying to inflate a balloon or play a wind instrument or something like that, that pressure, that diaphragm pressure that your band director or chorus director always used to talk about, that's really happening from the abdominal muscles. So like your rectus abdominis and the other muscles, they squeeze on the abdominal viscera, and so like your so they say the stomach, intestines, etc., as well as the liver, and kind of squeeze all those up, which is kind of push up the diaphragm. So that's going to make the diaphragm go up even higher. So that's going to decrease your thoracic volume even less. Okay. So when you see this figure or its partner here and talking about how typical inspiration expiration happens, this is entirely talking about what we're going to later call what your tidal breathing is. There are alterations to this if we're actively trying to expel air. Now, we can think about how this happens in addition to the cartoons, which I think are kind of helpful to look at. We can also think about what happens as, through like one ventilatory cycle. So we don't so much let the air escape as the air is moved because of the changes in volume due to Boyles Law. So the first thing that happens, like the muscle thing that happens, is the gray line in the middle. We're looking at the intrapleural pressure. As the muscles contract, that's going to cause them to pull away. It's going to cause them to pull away from their resting position, so that their pressure slightly goes down. And then the intrapulmonary pressure also goes down for like the first part of that inspiration cycle. But notice by the middle of this graph, it sort of reaches zero again. So in the intrapleural pressure, the muscle-caused pressure is at its lowest and it stops contracting. Then that's where the air stops moving. So air only moves when muscles are moving too. Now, during expiration, the opposite happens, where the chest cage decreases in volume, so that pressure goes up, which is going to cause the intrapulmonary pressure to go up, so that's also going to cause air to move out as well, until it again reaches equilibrium. So this graph, I think, is helpful to look at. I do sort of wish the traces were moved in opposite direction, were kind of flipped a little bit, but this is reasonable. Just like when you were learning the cardiac cycle diagram before, consider the contraction of the muscles, the gray line, intrapleural pressure, as being like muscle contraction in the heart. The red line for intrapulmonary pressure, that's showing you like the rate at which the fluid is moving. And then the volume in blue at the bottom, the amount of air that's actually moved, that's like your progress bar. How much air is coming in or going out, at different parts of the cycle. Now we can measure different potential lung volumes based on devices that are called spirometers. This is kind of a blurry figure from the place that I pulled it from, but basically what happens is, a subject is attached to this device where they breathe in and out of it. Usually their nose is plugged as well. As they breathe, it makes this drum go up and down inside a column of water, and then there's a balance with a little pen on the end of it that's going to record the different volumes. I know that you guys are familiar with the windmill spirometer that we used in laboratory, and we were doing that to measure what we called our forced vital capacity at the time. But there are other devices that we have for being able to measure like the amount that you can inhale as well. This device here on the right is called an incentive spirometer. This is often given to people who are in hospital, especially people who have fevers, people with pneumonia, because what this encourages them to do is to inhale as much as they can. Like the little arrow, that's on a little slider to try to incentivize the person to breathe slowly but up to a certain volume. The rationale for how this works is in someone in pneumonia, or if they have some other kind of lung accumulatory disease, they will by encouraging the patient to expand his or her lungs as much as they can, it has the effect of letting the pus or other kind of fluid that's accumulated inside the lung kind of lets it separate away from the alveolar wall and makes it easier to move, easier to get coughed out, so you can actually move some of that stuff around. Nurses will sometimes talk about the incentive spirometer as though it's some kind of magic device that makes your fever go down, but the way that it does it is by encouraging you to expand your lungs, so that you can kind of make sure that any chud that's in there gets moved out. This is a very common device that's handed out to people whenever they're in hospital because they want to make sure that you're actually, giving you're doing some regular deep breathing, because there are consequences that come from being sedentary for a long period of time if you're in the bed, say. So usually they'll want you to do that a few times an hour. So the different devices that we have, whether it's your pure like physiological spirometer or these other devices, there are different volumes that we recognize when we're looking at the lung capacity of a person. The tidal volume I keep on talking about is a sort of average baseline volume. So that about half a liter of air that gets moved, you know that you can inhale more on top of that, or you can blow out more beneath that. But that tidal volume is like when your lungs are approximately half full, I think is a fair way to think about it. Beyond the tidal volume, that middle filling, there are three other what we call just plain volumes. The inspiratory reserve volume is the amount that you can inhale on top of your tidal volume. Your expiratory reserve volume is the amount that you can blow out past your tidal volume. And the residual volume is like the maximum amount of air that you can move, basically the air that basically you can't move. I'm just going to go back a couple slides here. If you look at the cartoon of the person's lung there, so you see like when the lungs are at their smallest, when it just says RV there, that represents the residual volume. So that's like as much as you try to blow out actively from your lungs, there's some part that you can't compress. So like the air that's inside the bronchi, air that's inside the trachea, air that's inside your nose, like you can't like expel that air out, although it's a part of the pulmonary system. So that's what we call this residual volume, the amount that the volume that's there inside the body, but you can't actively move it. Okay, so from those four basic volumes come the other capacities. Your inspiratory capacity, the maximum amount that you can inhale, that's your tidal volume plus the inspiratory capacity. Your functional residual capacity is your expiratory reserve plus the residual volume. The vital capacity, that's what we measured in lab. That's where when we asked you to inhale as much as you could and then blow out all the way down to the bottom of what you could blow out. That's what we call your vital capacity. But your total lung capacity, we really couldn't measure unless we like waterboarded you and like poured water in there to measure what your total lung capacity was. Of course, we don't usually do that with patients, but that's just to give you a sense of where that all comes from. While we're talking about this, these are the kind of my accumulation of data of vital capacities that I've accumulated over the last few years. So we have men in blue and the women in gold, and the representatives from our class are shown in the red dots, obviously. So we see a pretty tight relationship between a person's height and what their vital capacity is. Whereas and it's for the stats nerds, I put the statistics down there at the bottom. There's a lot of spread around there. So oftentimes what's interesting to us is like how far above or below the line a person is. So when we were in lab and I asked you to keep track of, who is a runner, who played a wind instrument, who's a smoker, who has asthma, who's wearing a back brace, something like that, those are all going to have effects on like how high or low an individual is above or below the line. We're going to switch gears now, and we're going to talk about partial pressures of gases and the different things that we have to bear in mind if we're going to talk about how respiration happens, meaning internal, external respiration, which we call that exchange of gases from one fluid to another fluid. Now, this big table here is summarizing the atmospheric pressures of 4 different gases. So if we look first at the first column here, we know that nitrogen is the gas that has the greatest concentration, well, at least the greatest percentage of our atmosphere. Though we always kind of focus on the oxygen, that makes up a much smaller component of it. There's a little bit of water vapor and also a very small amount of carbon dioxide that's in the atmospheric air, or what we call the room air. Doctors usually talk about what people's blood oxygen carrying capacity is based on room air. So that atmospheric air percentage turns into a certain partial pressure. So if you remember from before, the total pressure at sea level was about 760 millimeters of mercury. But each of those gases produces a different component, a different amount of pressure individually. So the nitrogen, it's the most, it's got the highest percentage, so it also has the highest partial pressure. Oxygen has the next most, it has the next most level of partial pressure there. So the way that I think it's helpful to think about partial pressure is I always ask people to envision they're like at the bottom of a swimming pool. But imagine we had a swimming pool where like there are things of different density, like fluids of different density above you. Imagine a swimming pool where there's like water, and then you dump in a bunch of oil where there's oil on top of that, and then so they're going to separate out. So you can kind of like, just like there are the rows of this table, consider the partial pressure to be like a big column that's going. Each of those gases is going to be contributing a different amount to the total partial pressure. Now, this what I refer to as Dalton's law of partial pressures. That's there to tell us that there is a relationship between how much of a percentage there is of a given gas, which how much partial pressure there is. So the total amount of pressure is caused by the amount of gas and amount of that particular elemental gas in the mixture. Now, these values are different if you compare atmospheric air and the alveolar air. The alveolar air, it's still mostly nitrogen, but there's like less oxygen and much more, like 3 orders of magnitude more of carbon dioxide than before, and also way more water vapor. This is because the air that's in the alveoli is a mix between that fresh room air that's come in with that, air that's inside the alveoli that's come from the waste products of the cells. So the alveolar partial pressure is going to be a little bit different. The two that I want you to focus on for when we're discussing this later is notice that the partial pressure of air in the alveoli is 104, or let's say around 100 millimeters of mercury. But of carbon dioxide, it's about 40. That what we call PO2 and PCO2, those partial pressures are the ones that we're going to be tracing. Now, Dalton's law, so that basically determines how much of the pressures of moving gases in your body, but we have to kind of mix that with, combine that with Henry's law of solubility. Not every gas is equally soluble in water. Now, so the relationship that I showed here at the bottom, notice that carbon dioxide is the most soluble. Oxygen is only about 1/20th as soluble as that. Nitrogen is only 1/40th amount as soluble as carbon dioxide. So it's easier for carbon dioxide to get traveled as a gas in the blood than it is for either oxygen or nitrogen. Now, that's okay because we have hemoglobin. We evolved hemoglobin to be able to move the oxygen, to be like an attractive force that was going to kind of draw in oxygen past the point of where its solubility would allow it. So the hemoglobin is able to help with part of that. But nitrogen is in the blood, but at a very small partial pressures. But that's okay, because physiologically we don't use it for much. The only time when it becomes significant is if we're thinking about people who are deep sea divers, because if you've ever heard of the condition called the bends, that's the condition where people decompress from deep dives too quickly. And then, or if they're in a submersible, they come up too quickly. And that can cause the nitrogen gas to come out of solution into bubbles. And those bubbles will act like embolisms, which are little gas bubble blockages of small blood vessels. So people will have to go into a decompression tank in order to avoid that. In case you're wondering, there are diving mammals, things like whales and seals, and the question was asked for a long time by physiologists, how do whales avoid this? These really deep diving, like sperm whales, blue whales, how do they avoid getting the bends? And necropsies have shown the thing is they don't. They actually, their blood vessels are usually pretty ripped up by the time they die of natural causes, largely because it seems like they do succumb to the bends. Well, at least they have to kind of deal with what the consequences of it are, and we can see this in lots of vascular damage when they are necropsied. Where we're going to land with this lecture here is to talk about partial pressure gradients. Now, the way that I want you to think about this is kind of like the same old pressure rules as when we did the heart, where basically when gases are always going to go from where they are in high partial pressure to where they are in low partial pressure. I think those are pretty easy rules. Now we're going to focus, because this is kind of a tall figure in your book, I'm going to break this out and I'm going to zoom in on two parts of it. First, I'm going to focus on the external respiration part. So the bar graphs here, or histograms, well, they're really bar graphs, are those are showing you the different partial pressures of oxygen in red and carbon dioxide in blue. So the room air, when it's inspired, has this 160 millimeters of mercury of PO2, but only like 0.3 millimeters for carbon dioxide. Sorry. When it's mixed with the gas that's already in the lungs, that kind of mixes down to, there's a less partial pressure of oxygen and a higher partial pressure of carbon dioxide. So the blood, if you look at the blood vessel, the pulmonary arteries now, the blood coming to the lungs has a pretty low partial pressure of oxygen. It's only got 40 millimeters of mercury. But it's going to the alveoli where it's like 104. So oxygen will go from where it's in high partial pressure in the alveoli to where it's in lower partial pressure in the blood. So notice the partial pressure of oxygen leaving the lungs isn't all the way up to that 104 millimeters of mercury, just because it takes a certain amount of time for it all to diffuse across, but it's kind of mixed at that point. Similarly, the carbon dioxide, it's in really low partial pressure is in relatively low partial pressure in the alveoli, but it's in higher partial pressure in the when it's in the kind of the inverse happens with carbon dioxide, where it's in high partial pressure, although I don't show you the numbers in this frame yet, high partial pressure going to the lung. So carbon dioxide tends to leave the blood rather than enter it. If we look at the more distal part here, so we figured going from kind of clockwise starting on the upper right, so your blood that's leaving the lungs and going to the tissue capillaries, it really doesn't change after it goes to the left side of the heart. Flip up. So at the alveoli, it tanks up to like 100 millimeters of mercury of oxygen and 40 millimeters of mercury of carbon dioxide. Notice those values are basically the same after it's been through the left heart. That's because, as before, the heart doesn't really do anything to the blood, doesn't really have any interactions with the blood. All it does is it's just kind of moving it because the chamber walls are too thick. Now, those after that blood has left the left heart and gotten out to the through the systemic arteries to the capillary beds, the tissues at the bottom, notice, they're going to have like less than 40 millimeters of mercury of oxygen, but could be greater than 45 millimeters of mercury of carbon dioxide. So the oxygen is going to tend to go where it's in high partial pressure in the blood to where it's in lower partial pressure in the tissues. And carbon dioxide is going to do the opposite, where it's in slightly higher partial pressure in the tissues, so it's going to go into the blood. So the kind of after, notice for the blood leaving the tissues and entering the lungs, it's basically in equilibrium with what's in the tissue beds, where it's 40 millimeters of mercury oxygen, just like the partial pressure was in the tissues, and 45 of carbon dioxide, like it was in the tissues. So that's the story with this. I'm going to go back and forth a couple times now. So this, the inspired air, that's just kind of for your reference. But again, if you look at the alveoli of the lungs, when the blood, which starts off having only 40 millimeters of mercury of PO2 in it, it's going to get up to the alveoli and basically become in equilibrium with what the alveoli are. So it juices up from 40 millimeters of mercury up to a PO2 of about 100 millimeters of mercury. On the other hand, when it gets down to the systemic capillaries, it's going to now go in equilibrium with the systemic tissues as well. So it's going to unload that, because of the partial pressure of oxygen in the blood, it's going to unload that into the tissues. What really isn't shown in this figure is like the before and after of what happens in the tissues, but you can figure the tissues are going to look more like the it's going to look more like what the blood leaving the lungs was like. It's not going to go all the way up to 100 millimeters of mercury, but it's going to be at kind of an intermediate value. So certainly it's going to gas up with oxygen through this process. So I guess the name of the game when you're looking at this figure and considering internal versus external respiration, so again, internal respiration between the blood and the tissue cells, external respiration between the blood and the room air, it's really a story of these coming into equilibrium with one another, but the rules are always the same. The physics rules of gases going from where they're in high partial pressure to where they're in low partial pressure is the same old story as when we're looking at this. Now, a little bit here about if we were to zoom in on a single capillary, this figure at the bottom, that is showing, so notice this is like time in the capillary going, so from where it begins to the end of the capillary. So it takes less than a second for blood to move across this gauntlet here. Notice how the partial pressure of oxygen, which is on the y-axis, that shows basically how long it takes for it to gas up. And notice it really doesn't take very long for it to come in equilibrium with the room air. The table up at the top, this you can take a minute to look at it. I'm not going to walk through the whole thing, but the take-home message from this is that slow, deep breathing is going to, even though it's like the same amount of gas moving, it's going to have a higher effect of being able to ventilate the blood, meaning more oxygen is going to be able to get in with like slow, deep breathing than there is if you were hyperventilating, like shallow, rapid breathing, because you give as your tidal volume goes up, or basically the amount of volume of air inspired goes up, that's going to allow kind of dilute out that mixing of the blood that happens when it's mixing of the air that happens when it gets to the alveoli. So I guess the take-home message here is most people, you'll find when you go to the doctor's office and they measure your blood, they take your blood pressure and they take your temperature and they put that little thing on your finger that measures like your blood oxygen. Most people are at pretty close to 100%. Actually, that's measuring. I think that actually measures. It's not. We often talk about it in terms of percentages, but it's actually measuring your PO2. So people are usually in that, like, even people who are in pretty severe not severe lung distress, but people who have chronic lung disorders can still find themselves like between like 90 and 95% when they're at rest. But it's like the active, increased carbon dioxide conditions in the body that can cause where the real problems are for them. The last thing I want to talk about in this lecture is what we call ventilation-perfusion coupling. Some definitions now. Ventilation already. That's just breathing. That's a mechanical movement of air. Perfusion is a word that means how much blood is being passed through an area through capillaries. Sometimes when we're looking at the cats, we'll notice how there's some places where like the latex, the red and the blue, is able to, looks pretty clear, and other places not as good. I'll often say like, well, the perfusion was good there or less good there. Perfusion is basically how much those capillaries, precapillary sphincters are opened up, so it's going to allow blood to enter that area. Now, we're going to talk about ventilation-perfusion coupling because we're going to see that you want to have matched the amount of blood that's being sent to an alveolus with how much ventilation is happening. So to do the left column first, there's a mismatch here where if you have wide open capillaries, but the lungs aren't really an individual alveolus, which is being cartooned here, isn't inflated that much, that's going to cause that increased amount of oxygen is going to cause the arterioles serving them to constrict. And then like the after is what you want is when you have low ventilation, you also have low perfusion. So back when we were learning the different autoregulatory mechanisms of blood pressure within blood pressure, this is one of the things that's going to cause blood vessels to constrict, like high amounts of oxygen. So in this case, if you've got there's low amounts of oxygen here are going to make them constrict. So if you have if you're only doing shallow breathing, you're going to tend to have low perfusion in order to match those two. On the other hand, in the right column, when you have a lot of ventilation, when the alveoli are really expanded, that's locally going to cause a really low partial pressure of carbon dioxide, high partial pressure of oxygen, and that's going to do the opposite, where it's going to cause dilation of the capillaries going there. So again, in the end, you match the amount of ventilation, the amount of perfusion with the ventilation that's happening. So really, it's like the bottom part of this figure, which is what we try to go for. The top part of each of these figures shows like basically when they're mismatched with one another, and those autoregulatory mechanisms that we learned before are going to cause them to kind of come into balance with one another. That's what I have for right now. If you have any questions about the content here, be sure to load them up to the discussion board on Blackboard. You're welcome to answer each other's questions, but I'll chime in on them as well. And with this video and with any of the other ones, I'll be happy to get any of your feedback about it. Thanks.